Good afternoon. This past Sunday, I called my 93-year-old father to talk about things. And as we were discussing what I was about to do this week, he was quick to remind me of my grandfather's philosophy as a medical doctor. He mentioned that my grandfather always told him that a patient must never feel suffering. And then we went on to talk about pain, since we're talking about pain today. And he mentioned to me how at one point his father told him that he was more of a mind reader, much to my father's surprise, since he considered his father to be a scientist. In a way, the story illustrates what we heard earlier this year when we talked to physicians involved in workers' compensation, physicians who deal with treating pain. And what they told us is that when treating a patient with pain, we must look at the full condition of the patient, taking into consideration the psychosocial situation of the patient. Now, it's hard for us to imagine any of our friends or families who have not been affected by the opioid epidemic in some way or fashion. 116 people died from opioid-related overdose per day, according to the Centers for Disease Control and Prevention in 2016. They reported a prescribing rate of 61 per 100 person, 61 prescriptions per 100 person. Now, in workers' compensation, when we look at workers' comp claims, we find that the prescribing pattern is 3 times that rate of prescribing opioids. So let's take a look at what our data shows. Earlier today, Kathy shared with us that more than 2 out of 5 prescription claims received an opioid in 2016. That number is down 10% since 2012. Opioids are expensive, they're costly. The average prescription cost for an opioid claim is 4 times that of a non-opioid claim. And what that means for our industry is that 1 in 4 dollars spent on prescription drugs is for opioids. So let's take a look at what's happened in the last 5 years. Well, as you can see here, it's been a good 5 years for opioid decrease. The change in the average cost per active claim is a 9% decrease. Now, we break that down into 2 parts. Look at the green bars there. That's the price of opioids over the years, and you can see that they've been increasing significantly. On the other hand, the utilization of opioid has been coming down. Those are the red bars you see there. In fact, they've been going down considerably more in the last 2 years. You see the double-digit decrease in opioid utilization, overcoming the price increases and resulting in the 9% decrease in average opioid cost per claim. So let's delve deeper into this utilization factor. And here we look at 3 components: the change in the share of claims that receive opioids. We look at the change in the number of opioid prescriptions for claims that actually are prescribed at least 1 opioid, and at the change in the mix. Now, what you see here is that the change in share of claims is the dominant factor affecting utilization over the period 2012 through 2016. Those are the deep red bars that you see there. The number of opioid scripts per claim has also been coming down. Those are the light pink bars in the middle. What's left is the type of opioids, the mix in the type of opioids that we have in workers' compensation. We know that opioids come in different forms. There are pills, patches, vials, and we have even lollipops. And they also come in different strengths. So if we really want to know how opioid consumption in workers' comp is changing, What we need is a unit of measurement that is consistent, that tells us how the opioid consumption is changing on a global level. And so what we need is that unit of measurement. Now, the CDC provides such a measure. It's called the morphine milligrams equivalent, or MME. You can see from the table there that a 10 milligram Vicodin pill is roughly 10 MMEs. A 20 milligram oxycodone pill is 30 MMEs, and a Butrans patch is 36 MMEs per day. Now, what we've done at NCCI is translate these MMEs, which seem like a bit of a theoretical concept, into number of pills. So what we've done is we've translated those to what we call the oxycodone pill equivalent. That way, it's more relatable, and we're able to use number of pills of OPEs. So the 20 milligram oxycodone is essentially one OPE, and the others are as you can see there. Now, the reason we used oxycodone as the unit is because it's the drug that is most used in workers' compensation. Here are the 10 top opioid drugs used in workers' comp. And what you see here is that between the oxycodone hydrochloride and OxyContin, that's the number 1 and number 4, you've got over 25% of the use of opioid strengths, OPEs, oxycodone pill equivalents. When you add the Vicodin, that's the number 2 drugs, the hydrocodone bitartrate acetaminophen, at 15%, and then the Percocets, we're all familiar with those, right? The oxycodone HCl acetaminophen, then you've rounded up the top 4 at about 50% of the total OPE consumed. Now, notice also in the top 10 a couple of other drugs here. Methadone hydrochloride at the bottom, and Suboxone. Now, these 2 drugs are typically used to treat opioid addiction. And what that means, seeing those in the top 10, is that here in workers' compensation, we are already treating overdose. We're already in the business of treating addiction. And we're providing those drugs in order to do those treatments. Now, opioid use varies widely across states. Take a look at the 2012 experience. This is the amount of OPE, or oxycodone pill equivalents, for active claims for 2012. It varies widely from roughly 20 pills for Nebraska to over 100 in Montana. Now, when you bring in the 2016 experience, you can see that we've had a decrease for every single state over the last 5 years. When you put that experience together, you can see that in 2012, we had an OPE of 38 pills, and that came down to 25 pills in 2016. That's a 30% decrease in the amount of OPEs over the 5-year period. When you look at claims that had at least one opioid, the picture is a little bit different. Sure, it is a decrease, but it's only a 10% decrease, coming down to roughly 160 oxycodone pill equivalents. And what is surprising here is that, in fact, the OPEs per prescription has stayed relatively flat. In other words, the key feature in the drop in utilization is the fact that opioids are not being prescribed to begin with. So let's take a look at when opioids are being prescribed relative to the claims life. And that's the next picture here. This shows the amount of OPE prescribed per year for 2012 by claim maturity, the time from the date of injury to the time that we are reporting the data. And what you can see is a pattern that is expected. The older the claim, the more intense the amount of opioid strength. At 15 years, we have more than 1,000 OPE, more than 1,000 pills being prescribed on average per year. That's 2.5 oxycodone pills a day. Now, when we bring 2016 experience, you'll see that at every age, we are seeing a drop. So when we break down the drop in overall OPE, what we find to be interesting here is that claims that are between the age of 2 and 5 years are the greatest contributors to the decrease in overall OPE. Over 35% the decrease. What's interesting here in this slide as well is when you look at the claims that are 10 years or over, they make up 50% of the total oxycodone pill equivalence utilization. In other words, the opioids, 50% of all the opioid pills in 2016 were given to claimants that were at least 10 years after their accident. In fact, when we sort claims by the intensity of opioid usage, we find that the top 10% of claims, those that we call here the heavy users in red, consume almost 80% of the total oxycodone pill equivalents. The top 10%. The next 20% consume roughly 15% of the OPE, and the mild users, the 70%, consume a mere 5%. Now, this concentration of opioid use can be explained in part by the severity of the claims and the amount of pain that is associated with the severity of the claims. But it did lead us to look further to understand better the intensity of opioid use. Back in March of 2016, the CDC published guidelines on prescribing opioid. And those guidelines, among other things, provided daily doses of opioids. The usual, typical daily dose is a 30 milligram of opioids, or 1 OPE per day. Now, that's the typical dosage. The CDC went on to say that prescribers must assess the dangers of increasing that prescribing pattern to beyond 50 MMEs, or over 600 oxycodone pill equivalents per year. And then the CDC went on to say that clinicians should avoid prescribing beyond 90 MMEs per day, or 1,100 oxycodone pill equivalent per year. And here's what our workers' comp users have done over in 2016. You can see from the chart that mild users and moderate users are well within the CDC guidelines on average. On the other hand, look at the heavy users, and we see over 1,200 oxycodone pills. That's well above the 1,100 that the CDC warns against. Now, these numbers vary by state, and when we look at the heavy users in all the states, we find that for 2/3 of the states, the heavy users exceed that CDC avoidance level. And 1/3 of those states exceed those levels by more than 50%. Looking at prescribing patterns, we see that in workers' compensation, the mild users are typically prescribed 5 prescriptions per year, 2 for opioids, 3 for non-opioids. The moderate users are prescribed 3 times those amounts, and heavy users are prescribed an average of 40 prescriptions per year, 40 prescriptions. 17 of those are opioids, and then 24 are non-opioids. Kind of made us wonder, what else is these people being prescribed? Well, opioids have side effects, right? Nausea, vomiting, and psychological impacts. So what we found is that, in fact, along with the opioids, there was a host of different types of drugs that were being prescribed. When we were talking to the doctors earlier this year in preparing our series on opioids from the doctors' perspectives, they brought to our attention a very important phenomenon, and they called it the polypharmacy. Polypharmacy is when doctors are prescribing multiple prescriptions to treat the various disease or cases for a patient. Now, what they mentioned was that they have seen all sorts of combinations of drugs, many of them having severe interaction with the opioids. For example, somebody could have a chronic pain taking an opioid and then taking a benzodiazepine or such as a Xanax for anti-anxiety. When these drugs are taken, and if they're not really taken as prescribed, one of the possible features that can happen is, unfortunately, the suppression of the respiratory system for the patient. Now, we know that there were studies about benzodiazepines. These are the drugs that are anti-anxiety and that treat insomnia. And there were studies about the combination of benzos or benzodiazepines along with opioids. What we find in our experience is that for heavy users of opioids in workers' compensation, 1 in 5 of those heavy users have also a benzodiazepine being prescribed during 2016. Other users have also benzos prescribed, but to a lesser extent. And benzos are not the only drugs that are being prescribed along with opioids. Take a look at the list of top 10 non-opioids that are prescribed along with the opioids. You can see that 8 of the 10 have some level of drug-to-drug interaction with the opioids. These are the top 10 for the heavy users. Now, what we heard from the doctors as well is that prescribing patterns have come under greater scrutiny and that physicians are more aware of this polypharmacy phenomenon. Look at what happened since 2012. Now, what you see here is clearly a big decrease in the benzos and opioids, as well as other sedatives. So that is the result of some of the latest efforts in terms of bringing to life what opioids can do and their ultimate effects. You see here the plus 37%. This is largely due to the use of gabapentin. That's a drug that's often used to treat neuropathic pain. Now, back in July of 2016, 40 governors signed a compact to address opioid addiction. Since then, we have seen some 1,700 bills regarding opioids, some dealing with addiction prevention, some with the treatment of addiction, yet others putting limits on MMEs, such as what we've seen most recently in Oklahoma and earlier, a couple of years ago, in Maine and in Massachusetts. We've also seen increased importance given to prescription drug monitoring programs and a host of other provision to address opioids. Now, the question is, if not opioids, then what other alternatives might there be? And there are alternatives. In terms of non-drug treatments, we see physical therapy as a possibility. There's acupuncture, yoga. Some other alternatives lie in the area of psychological treatments, such as biofeedback, cognitive therapy, behavioral therapy. There are also other drugs, such as NSAIDs, gabapentin, as we mentioned earlier, and most recently, a story on NPR showed how in Colorado, 10 ER departments use the alternative of lidocaine and ketamine instead of opioids, and that was quite successful. The question that remains in our mind is there an alternative that has come under great consideration in the most recent 2 years that could be perhaps a way to assist with the treatment of the pain, or perhaps to replace the opioids? Does marijuana present such an alternative? And where are we in workers' comp in terms of looking at these alternatives and seeing if they can take hold.